Thank you for having me. So Greg made some suggestions for me with the outline and really kind of stumped me a little bit because there were a lot of different things and a hard story to tell. But what was very clear to me is that I don't want to repeat what others are doing, and they've done an extraordinary job with exciting immunotherapy. So I translated all that to sort of three things that I want to show you today, sort of roughly three abstracts. So there's one abstract, an innovative way to track how patients feel, excitement in the world of AlAmyloidosis, and that also a reminder that transplant is still an option for eligible myeloma patients. So that's kind of what we're going to talk about. And so this first abstract that I have for you here is a really interesting novel abstract by Dr. Corday, which is looking at wearables and electronic patient-reported outcomes to understand quality of life in patients. And so what she did, it's a small study, it's only 40 patients, two cohorts. The cohort A were patients under 65 and cohort B over 65. And what they did is they gave them devices, a wearable watch, and also a way to comment on how they were feeling, filling out surveys, what we call patient-reported outcomes. And they measured them at various points, baseline, and then at the end of prior to transplant after 6 cycles. And so here you can see cohort A, median age 54, a younger group, and then cohort B, the older group, age 71 as a mean. And you can see they got a variety of different therapies that wasn't pre-specified. And so they gave them these watches, these Garmin VivoFit devices, which patients were supposed to wear continuously. And they also gave them the ability to do electronic surveys using their smartphones, so pain scales and just other quality of life measures. And the goal here was to first just see if it's feasible, see if patients could and would wear it 60% of the time, so valid information could be collected. And the answer is yes, it ended up being very feasible. And then also just seeing how the watch, so counting steps and also watching sleep, how well that correlated with how patients said they were feeling. So if we focus on the left-hand part of the slide, you can see that amongst those patients in the less than 65-year-old group, the number of steps on average that patients were taking was about 6,000 steps on study. And throughout the study, they went up to about 7,200 steps. That wasn't a significant change, but when they looked at the older group, and again, we're looking at small numbers of patients here, 12 patients, you can see that indeed the number of steps increased quite significantly from just under 3,000 steps up to 5,000 steps per day. So kind of proof of concept that patients with as they get their chemotherapy are actually increasing their activity. Perhaps some of that is just going to appointments, who knows? But again, they are increasing their steps and activity. And then they also looked at response rates. So on the left, patients who have what we call a very good partial response or better. And you can see that there was indeed over time, which is sort of going from left to right, an improvement in the number of steps that patients had. And for the patients who didn't get as good a hematologic response, and again, this is only 7 patients, there initially was an improvement in their number of steps, and that may have trended down a little over time. They then next looked at the quality of life surveys that they did. And so there are a number of these instruments that ask patients questions. And so again, what we're seeing, if you sort of focus on the leftmost side of the slide, it's what we call the instrument, the survey type that it was. And then the next column is which domain they're looking at. So the first row is going to be physical function. And you can see if you follow across, the baseline score was a 75 out of 100. And then over time, during that 6-month period, there was a trend to an improvement of about 12 points. And then if we look at just the overall health status, again, if you sort of focus on the column, the second most to the right, it was an improvement by 10 points, which was an improvement. Then the next row, disease burden symptoms, the burden of symptoms went down, which is another good thing. So almost 10 points it went down. The patient's future perspective, how they saw the future, that actually went down a little bit too. Again, small numbers of patients, and there might have been like this impending stem cell transplant in front of them that might have spooked them a little bit. But really kind of very interesting that just patients saying how they feel, getting a sense of what's going on and how things are actually getting better. And then what this slide they're doing is the leftmost column is basically, again, the readings, the number of steps, the patient activity. And then the next column is, one of the survey domains. So how physical function is. So if we look at the first row across, we see indeed over time patient activity went up, and that correlated or went along with increased physical function that patients reported themselves. If we go to the next row, you see increased patient activity went along with an increase in just their quality of life according to this particular survey. And then again, the third row, when you look, patients' activity went up, and that correlated with a reduction in patient symptom burden. And so this is, very exciting to really capture what the experience of patient is. I know you've all seen, these toxicity slides that we show, and it's just a gamish of what the doctors actually are surmising by asking questions and so forth. But really, hearing it straight from patients' mouths and also just getting a sense of what's going on, I think is really the future. So I thought that was exciting. And I would say we want you to help physicians with patient-reported outcomes, because I think in the long run, that's going to help us help you better, both in terms of understanding toxicity of drugs and also just really doing proper interventions to help you feel better. So the next thing I was asked maybe to talk about AL amyloid, and I hope I don't bore you too much with this since this is a myeloma crowd. But I will throw in that if you are experiencing higher than expected side effects with treatment, the evil stepsister called AL amyloidosis or light chain immunoglobulin amyloidosis could be coming along with the myeloma. Now, that's really only 10 to 15% of myeloma patients. But what is amyloid or AL amyloid? So again, at the top of that picture, you see a graphical representation of a bone marrow with then the little plasma cells that reside in the bone marrow. And then what happens is we make immunoglobulins, which that's your M protein, M spike, myeloma protein, whatever that your doctor is typically following. Well, in a subset of patients with myeloma or just plasma cell disorders, these immunoglobulins can fold on themselves and actually be directly toxic to a number of organs within the body. They can be directly toxic, but more they form these fibrils that just kind of just gunk into tissues, making them sick. So it could be the heart, the liver, the kidney, the gut, the nerves. And so if at presentation, if, at diagnosis, you had really profound fatigue that was beyond what your hemoglobin would, the degree of anemia or the degree of renal failure or the degree of hypercalcemia, certainly your doctor should have been thinking, is there amyloid? If you have a big tongue or unusual bruising on the face or the neck, or your jaws actually get tired to chew, or if you have symptoms of heart failure like lower extremity edema or swelling, or excessive shortness of breath or waking up short of breath in the middle of the night. These are all potential clues that amyloid could be going on and affecting the various organs. If the protein, your urine protein, if that's excessive and it's not all the myeloma protein, or it's not, the majority isn't the myeloma protein, there could be amyloid riding along. And then, of course, neuropathy. We know that drugs can cause neuropathy. So again, a lot of people have neuropathy, and that doesn't mean that, you are developing amyloid per se. But if you presented with significant neuropathy of burning or tingling or excessive lightheadedness or dizziness, or a lot of issues with your bowels that wouldn't be attributable to narcotic pain medicines, again, amyloid would be something to consider. And so the biggest excitement in the world of amyloid right now is this study, the Andromeda trial. And again, this is, amyloid is the evil sister and the poor sister of multiple myeloma. But this is a big randomized trial that was conducted for amyloid. It's big, and essentially a very straightforward design. If you look at the orange, that is patients getting Velcade or bortezomib, cyclophosphamide, and Dex, and they do that for 6 cycles, roughly 6 months, versus patients would get the same VCD, but they would also get subcutaneous daratumumab according to the usual daratumumab schedule. And then at the completion of that 6-month time frame, the patients who were getting the DARA as part of their treatment would continue with the DARA maintenance, and the VCD alone, the orange folks, would have no therapy. They'd be off of therapy and they'd be observed to see what happens. And with that, the response rate, the complete response rate, you can see that just the VCD or CyBorD, 18% of patients without the daratumumab got a complete response, a complete hematologic response, but 53% that got the dara-CyBorD got a complete response. Now, this trial is kind of similar to a cyclone trial. That was the trial that was in myeloma. That was actually dara, VMP, Velcade, melphalan, prednisone. They're kind of cousin trials. Patients with amyloid had higher response rates even than the myeloma patients in that kind of similar trial. And then just overall response in general, if you look at very good partial response, 79% versus 49%. And so, and the response rates were even more rapid with the 4 drugs as opposed to the 3 drugs. And then again, remember I said amyloid can affect organs. People can have, often amyloid patients, their bone marrow doesn't look that sick, but it's the rest of them that look sick. So their hearts are sick and their kidneys are sick. And so here we do what's called organ response. And so again, you can see in purple, the patients that got the 4 drugs had almost twice as much an improvement in their heart. And the patients who had kidney involvement, you can see to the right, again, twice as many patients had kidney improvement getting the 4 drugs as compared to the 3 drugs. And then there's this new expression called major organ deterioration, progression-free survival. But again, you can see that the upper line, the purpley line, as compared to the orange line, again, better, much better progression-free with the 4 drug than the 3 drug. And so this sort of recapitulates what we're seeing, early in myeloma, that daratumumab is really helpful. But what was so exciting, because there is, until now, until January 15th, 2021, there was not one drug FDA approved for amyloid. We always sort of piggybacked on myeloma's back there, trying to use drugs. So this was accelerated approval and a lot of excitement. But just a quick back to myeloma and ASH. I just want, because I don't think it was on most people's topic about transplant still having a role, and perhaps Dr. Borrello may touch on this, but I just wanted to highlight just 2 studies really quickly, just to, get us back to reality. I mean, the CAR Ts and the BiTEs are definitely the future and the present, but there's still, the standard stuff that we do. And so this Forte trial is a really important trial. And it was a 3-arm study done, led by Dr. Gay. And essentially, if you look at the green at the bottom here, it was basically 12 cycles of KRD, so and no transplant was one group of patients. And then if you look at the light blue, that was 4 cycles of KRD. So KRD would be carfilzomib, Revlimid, Dex. And then followed by a single transplant, followed by 4 more cycles of KRD. And then the yellow is basically carfilzomib, cyclophosphamide, and Dex, followed by a transplant, followed by 4 more cycles of the same. And then patients had a secondary randomization. And what I think was just really amazing and quite striking is what you see in terms of progression-free survival and overall survival. If you focus on the right-hand most column, you see the loser, the KCD. So again, using cyclophosphamide with carfilzomib is far inferior to using carfilzomib and Revlimid. You need to have that class of medicine, that what we call the proteasome inhibitor, like carfilzomib, bortezomib, ixazomib, etc. And an IMiD like a Revlimid. In Europe, they use thalidomide. We don't use much of it in this country, pomalidomide, and some dexamethasone as an important induction. And even the 12 cycles of the KRD was better than the KCD with transplant, both in terms of progression-free survival and overall survival. And then in terms of the KRD plus the transplant, that really was the winner in terms of progression-free survival. So 3 years, more than 3/4 of patients had not progressed or died. And the 3-year overall survival, it was pretty much a tie at this point between those getting the KRD with transplant versus not, but more time will need to be followed. But I think it's just really wonderful to see at 3 years that 90% of patients are alive. Of course, we want it to be 100%, but this is progress for sure. In terms of the maintenance, the KR versus, so using maintenance with 2 drugs, the Revlimid and the carfilzomib versus just using Revlimid. Again, at this point, there definitely are deeper responses and better progression-free survival, but no difference at this point in overall survival. So more to follow. I don't think anybody thinks it's a standard yet, per se, to use KR, unless patients have high-risk cytogenetics, perhaps. So then one last thing is the transplant, the IFM 2009 study. And again, this one's been presented a million times at this point, but again, it was this notion of doing transplant versus no transplant. So on the left, RVD, and collect stem cells, but don't transplant, and give only a year's worth of Revlimid maintenance, not forever, just a year. Versus on the other side, transplant, 3 cycles of RVD, a transplant, an auto transplant, and 2 more RVD, and then a year worth of Revlimid. And what you can see here is, again, a progression-free survival that is superior with the transplant on the right, so 47 months progression-free survival versus 35. But the overall survival is not yet different between the two. Whether it ever will be, we don't know. But at 8 years, again, nearly 2/3 of patients are alive. And that, again, I'm old enough to really be impressed by this in terms of the fact, when I started, patients, average was like 3 years for people to live. So, to be doing this well. And again, now we have all these other exciting therapies. It's really exciting times. And so what does this all mean? I think there's really innovative ways to track how patients feel, and this is going to really influence how we take care of you. Amyloid, the evil sister, is a new standard and pretty exciting stuff. And certainly, some of you might have AL. I don't want to get you worried that you do, but your doctor should be sort of always thinking of that possibility because of the symptom burden that goes along. And then transplant, all this exciting stuff happening, but yet in 2021, transplant still is considered by many to be an important part of therapy. The jury is out in terms of overall survival benefit yet, because again, we need to follow these trials more than 10 years in order to know whether survival will be different, whether patients get a transplant up front or not. And with that, I will end and move on.